I'm very happy to be here and to discuss with you the data that we had on the use of MammaTyper in predicting response to neoadjuvant therapy in HER2-positive breast cancer. So we know that neoadjuvant therapy has become the standard of care for HER2-positive breast cancer, but unfortunately we know that only about half of these patients achieve a pathological complete response. So half of the patients do not achieve the pathological complete response. And these preliminary data were presented last year at the European Breast Cancer Conference, where we presented, a first small cohort of patients where for which and in this patient we analyzed the expression of we tested MammaTyper kit in this setting. And this was the poster that we presented. And as you can see, we tested 49 formalin-fixed and paraffin-embedded preoperatory biopsies of breast cancer with HER2-positive score 3+ HER2. So 3+ HER2-positive cases in core biopsies. And we tested with MammaTyper, and we used a machine learning Python-based decision tree algorithm to study the performance of the prediction of MammaTyper in comparison with the pathological complete response. And the results were very interesting because, as you can see, the specificity, sensitivity, and all the other parameters were very high. However, we divided the cohort between HR-positive cases and HR-negative cases, and these two cohorts were well balanced. But they were not well balanced between those that achieved pathological complete response versus patients that did not achieve pathological complete response. We had 30% of cases that did not achieve a pathological complete response. So this, compared to this parameter, the cohort was not well balanced because of the low number of cases. So in conclusion, we propose MammaTyper as an interesting tool to discriminate patients with HER2-positive breast cancer that may achieve a pathological complete response. So an interesting tool to predict the pathological response. But we also stated that we had to validate this data on a larger cohort of patients. That's why we asked help to our colleagues and friends from University of Catania and Humanitas Istituto Clinico Catanese that were eager to help us, and so we collected 161 cases. So preoperative biopsy cases of breast cancer, HER2-positive, score 3+ cases. And at the end, we tested 158 cases, were balanced between, as you can see, HR-positive, HR-negative, more balanced for the comparison to PCR and PPR. So you can see that in this new cohort, we had a 40% of cases with PPR, so a larger number of cases of patients that did not achieve. So it was more balanced. But we wanted to with the aim to get a more accuracy, we wanted to add the data from MammaTyper with clinical data. So I coined this new term, this acronym MT-CLIN, which is this tool that had MammaTyper kit results with the dimension of the tumor, so the the size of the MRI dimension of the tumor, plus the clinical node status. Well, results are very interesting and are promising because, as you can see, MT-clean reaches very high levels of accuracy, more than 93% of accuracy, very high levels of sensitivity and specificity, and these are results from the HR negative cohort that, as we all know, these patients with no expression of estrogen receptor are more prone to obtain a PCR. But the interesting thing is also on the cohort of patients with HR positive breast cancer, the accuracy, sensitivity, and specificity are very high. Lower, but very, very high, however. So, to conclude, MT-clean may discriminate patients with HER2 positive breast cancer who will achieve PCR from those who will not. And this may represent a powerful decision tool in terms of escalation and de-escalation of treatment approaches. In terms of escalation and de-escalation approaches, we have to know that the right balance between appropriate systemic therapy and avoiding unnecessary side effects to enhance the quality of life of our patient is very important. We also need to take into account the financial toxicity, because if we perform a dual blockade, well, for our national health systems, it's not so cheap. So we have to take into account also the financial toxicity. And if we think that this tumor will not achieve a pathological complete response, maybe our oncologist may suggest to escalate with a double block, or if the tumor we know that the tumor will achieve a pathological complete response, maybe we can de-escalate. And so maybe treat these tumors with a monoblockade target therapy. And this is interesting in small tumors, and we all know that the small tumors, T1 and 0 tumors, may be the subgroup of ER-positive breast cancer that still remain a challenge in the treatment, and maybe this MT-clean tool could have a space of opportunity. So future perspectives that are not so future, but because we are working now on these aspects, is of course to validate on a larger external cohort of patients, but maybe also in a prospective way, not only in a retrospective way, which is maybe the most intelligent way to work with. And we are focusing also, as I told you, on small tumors, T1 and 0 breast cancer. And also another important aspect could be how MT-clean could predict the recurrence of these tumors, because we always think on the most important endpoint is the PCR, but maybe another important endpoint is the recurrence of these tumors. So with this, I want to thank you all, and I want to thank all the colleagues that work with me on this project, and thank you.